there are probably microscopic residual cells along the carotid sheath which will require further treatment. And the dose limiting factor there is the skin. So in a salvage neck dissection following previous neck dissection and radiation therapy, we would routinely sacrifice the skin of the neck in the upper part. Do the completion neck dissection, excise the recurrent or persistent disease, put in a regional myocutaneous flap or a free flap, so you now have non-radiated soft tissue and skin. And rather than do brachytherapy, where also you have dose limitations, we would give a second course of post-operative IMRT-based full-dose radiation therapy. That may have more value than brachytherapy, either with IORT or after-loading implant, both of which have dose limitations.
Thank you very much. Professor Wendt.
Yes, this is true. We have not much experience in doing brachytherapy in the lateral neck. But these are problems because the mass is removed surgically, and there is not very much space to introduce the tubes, and there is not much space between the tubes and the skin. And this is true. We have the problems with the skin. There is some risk of fistula, and it needs probably in a second surgical procedure some plastic surgery.
Yeah, Jan, please, microphone.
A few questions regarding unknown primaries. In how many percentage have the PET scan really improved the diagnosis, and you have found the primary? When we have done the routine examinations that we are doing, CT, MR, biopsies from the tonsils of tonsillectomy, biopsies from the base of the tongue and nasopharynx. The second question is, if all this is negative, do you include the nasopharynx in the radiation field?
No.
May I just...
It adds quite a lot of morbidity to the patient.
I think it is a very important question when we define carcinoma of unknown primary. Do we do it if we have had biopsy from the tongue base, remove the tonsils, a biopsy from the nasopharynx, a complete panendoscopy, or do we do it if we, and so on?
Therefore, we have to define what the diagnostics we are using. It's the same with the NO neck.
Yeah. So, please.
Clinical practice, I can emphasize the need of doing the PET. We do routinely PET in these patients before a biopsy from the nasopharynx, because this is a source of wrong positivity. I think the treatment pattern for radiation oncologists has changed with the introduction of the PET. And if all these results are negative, the PET is negative, your surgical procedures are negative, we are reducing the volume, at least in our institution, we are reducing the volume we are treating. Despite we have IMRT and can exclude the parotids, but I think it is not longer justified to treat a very large volume if we have a very good diagnostic ruling out some primary in the nasopharynx.
How much do you reduce the field?
We treat only from the base of the skull to the clavicles. We irradiate both sides from lateral with a normal technique. Exclude the tonsils, exclude the mouth.
Exclude tonsils.
To spare, to spare the mucosa.
I'm sorry, you exclude the tonsils.
Yeah. Well, the tonsils are in part in the volume because we use a left and right opposing field technique. So part of the tonsils are included, but it's not the aim to do so.
Yeah, Professor Werner?
But I think the tonsils are very high-risk organs. So for the primary, and also the base of the tongue tonsil. Since 15 years in this situation, we always remove the base of the tongue tonsil laser surgically. And since we are doing this, we have a higher detection rate than before, where we did some blind biopsies. And so I think the base of the tongue tonsil, but of course also the palatine tonsils are very important, and they should have, if something should have a high radiation dose, they should have this. And yeah, this is my opinion.
So you really rely on the PET scan then, that if the tonsils are negative and the base of tongue is negative, you do not include that in the radiation-free data?
We rely on the PET
PET
finding as far as the nasopharynx is concerned.
Yeah.
And if the tonsils are removed surgically and the histology is negative, so the tonsils are included in the volumes, but it's not the aim, because we use left and right opposing fields, and the floor of mouth and the tonsils are included. Of course.
Yeah. Bhuvnesh and Kerry.
So I think the first thing to be said is there's no role for a blind biopsy in looking for unknown primary. You have this very large field of mucosa, and you go in and you randomly pick a spot, and if you picked it, it's like throwing a dart. You may get lucky and you hit it in the center, but most of the time you won't. I think the key is, in agreement with everything that's been said, is to rule out the nasopharynx. If you have a level 2 neck node, it's not going to be an oral cavity lesion, because you'll see that on your evaluation, either in the OR, either in your office or when you go to the operating room. So it's got to be a nasopharyngeal or laryngopharyngeal tumor that you're probably dealing with. And if you exclude the nasopharynx, everything else is somewhat irradiated by your opposing fields anyway. So what you're saving, you can't re-irradiate the tonsil. Once you've given your lateral opposing fields, the amount of dosing that you've given to the tonsil fossa doesn't allow you to give a second course of radiation. So giving shortchanging the mucosal irradiation in that case doesn't make sense. With everything said, the only blind biopsy that we do, I would say, is a ipsilateral tonsillectomy, because often there is tumor hidden within the crypts that is not detected as part of your routine evaluation, and certainly not detected if you just biopsy the surface of the tonsil. I think the bigger question here is, if you have an unknown primary and you've done a neck dissection and you don't find the primary, do you need to give chemo-RT, or do you give RT alone in that situation?
Yeah, but what I would like to point out is exact this situation. So you do ipsilateral tonsillectomy. We do this also, but we do additionally an ipsilateral removal of the base of the tongue tonsil, and our detection rate is higher in our, of course, small group, but it's now 15 years, in the base of the tongue tonsil with very small carcinomas compared to the palatine tonsils. So it may be comparable, but if you do the ipsilateral tonsillectomy, then you can do additionally, or you should not do it, but you can additionally resect the base of the tongue tonsil. So I think this is important. Then you excluded the nasopharynx, and then you know, the tumor is not in the nasopharynx, the tumor is not in the base of the tongue tonsil, and the tumor is not in the palatine tonsil. So where is the tumor? And then you start with the radiation therapy. And I think this is also a question. With one lymph node metastasis, level 2A, 1.5 centimeters in diameter, why do you go on? Of course, everybody will go on, but there are, I think we have to think about this. If there are some cases, to stop and to observe. If you have very good patients, you can observe them.
Kerry?
No, I think that the discussion about the unknown primary is always very interesting, because what is one person's unknown primary is another person's discovered primary. And I've always felt that the optimal time to try to find a primary tumor is not when the patient is asleep and in the operating room, but is in the clinic. I still believe that if you do a very thorough clinical examination, both in terms of looking, in terms of palpation, in terms of palpating after you're looking, to see little subtle areas of bleeding, to use pill retractors to expose portions of the tonsil, very often you can find a suspicious site. Someone asked about PET scanning. We've done PET scanning for many years, also looking at unknown primaries. I've yet I've only seen one case in my entire life where a tumor was submucosal in the tongue base where I could not feel it.